All right. Well, it's just at noon now, so why don't we get started? Welcome, everybody. I'm really excited to have you all here. I know people will slowly trickle in, but for those who have not been able to meet yet, my name is Dr. Tess King. I'm one of the inpatient chief residents over at UW. And today we have a really great joint grand rounds between the Department of Global Health and the Department of Internal Medicine. And so to introduce our speaker in our talk today, I want to welcome Dr. Jason Bestie to our talk as well.
Thanks so much, Dr. King. As Dr. King mentioned, my name is Jason Bestie. I am an infectious disease physician in the Division of Allergy and Infectious Disease and in the Department of Global Health. And on behalf of the Department of Global Health, I would like to welcome you to our second joint Global Health Grand Rounds of this academic year, co-hosted by the Department of Medicine and the Department of Global Health. And today I have the honor and the privilege to introduce you to our very special speaker who joined our Department of Medicine this past fall as the director of the Global Cardiovascular Health Program, Dr. Christopher Longenecker. Dr. Longenecker is a cardiologist who earned his medical degree from the Ohio State University. He trained in internal medicine at the University of California, San Francisco, and cardiology at University Hospitals of Cleveland. This past fall, after spending 8 years, I should say, in Cleveland at Case Western Reserve, he joined the University of Washington in November of 2021. Dr. Longenecker's research, which is primarily conducted in the US and in Uganda, focuses on mechanisms and prevention of cardiovascular disease in people with HIV, with a secondary focus on quality of care and outcomes for people living with rheumatic heart disease. His research has been funded by the NIH, the American Heart Association, and Medtronic Philanthropy. Dr. Longenecker, again, thank you so much for taking time out of your busy schedule, especially now that I know you're on service, you were just mentioning. We really appreciate this. We're really looking forward to your talk today. With that, I'll pass it off to you.
Thank you so much for that kind introduction, Jason. It's an honor to be here and just hoping to have a lot of fun today, sharing with you the work that I've been doing over the last 10 years in Uganda, tell you a little bit about myself and talk a little bit about the Global Cardiovascular Health Program and where we hope to go with that. If you want to get in touch with me, feel free to tweet at HIV Cardiodoc, that's my Twitter handle, or email me at ctlongen@uw.edu. Here are my disclosures, no disclosures relevant for this discussion. So an outline of what we'll talk about today. I'll begin with an introduction to who I am, where I'm from, and hope that will be helpful as we hopefully meet in person sometime soon and talk about more than just work. I'll talk a little bit about these two broad areas of work that I do in HIV and then rheumatic heart disease. And then the title of the talk really implies that all of this work relies heavily on sustained and equitable partnerships with people in the settings where we work, and in my case, that being Uganda. And then at the end of the talk, we'll talk about the Global Cardiovascular Health Program and some parameters for vision and mission to achieve that vision for the program. And in terms of objectives, really what I really want to do today is get you excited about the opportunities for global cardiovascular health research and education here at the University of Washington. As many of you know, there's a lot of really good work already going on here before I came. People like Greg Roth and Kate Farquhar, others doing really interesting things. But I think there's even more potential for interdisciplinary collaboration across many schools in the university to do some innovative work in this area. So get excited. But first, I'll talk a little bit about my background. So I did not go to an Ivy League school for undergrad. I went to a small liberal arts college in Virginia called Eastern Mennonite University. Now, when many people think about Mennonites, they may think of the Amish or the horse and buggies that they used to get around. But Mennonites are actually also known for the disaster relief work that they do, peace and social justice work, all around the world through organizations such as Mennonite Central Committee. And in fact, the 2011 Nobel Peace Prize winner, Lema Bowie, shown here, was a graduate of Eastern Mennonite University graduate program. So I left EMU in Virginia in 2002 to attend medical school at the Ohio State University, big Buckeyes fan, and spent 4 years there before traveling out west to the University of California, San Francisco, where my wife was doing a PhD and I did my internal medicine. We traveled back to Ohio again, to Cleveland, where I was a cardiology fellow at Case and UH, and then joined the faculty for 9 years before coming out west again. My wife is Allison Webble, and around 2019 or so, we were at a point in our careers where it was time to look for some new opportunities. And she was recently named the Associate Dean for Research at the School of Nursing, and so started in April of last year. And so over the summer, we moved to Seattle with our two children, Maddie and Lizzie, who are 8 and 5. And I started in the middle of college football season in November. I love college football and look forward to attending some of the Huskies games this fall. So I'd also like to acknowledge my father, Randy Longenecker, recently retired Assistant Dean for Rural and Underserved Programs at Ohio University. And the reason why I mention him is that, through our conversations about rural health over the years and work that he does here with colleagues at the University of Washington, there are a lot of similarities with the challenges and even opportunities that we see in global health. And so I think there's a real opportunity to think about shared innovations and reciprocal innovations that can be applied to both settings. We'll talk about that at the end as well. But this talk is titled The Importance of Building Equitable Partnerships. And I think we have to acknowledge that we live in a world where there are structural disparities, and to build equitable partnerships means to recognize and address those disparities. And these include disparities of race and ethnicity, but also sex and gender, issues of north-south relationships, rural and urban, as I just mentioned. And we need to think about where do we invest resources and how do we treat people so that equity can be achieved. And I think we've been really intentional and proud of the work that we've done in the work we do in the United States in cardiovascular disease and people living with HIV, but also in our global health work and thinking about helping to support nurses with who are working with people living with rheumatic heart disease, such as Somali, shown here, and then partnering with trainees through diversity supplements in our extra CVD study in the US, such as Angela Afa, shown here from NYU. She's been a critical partner to our work in human-centered design, which I'll talk about in the Palesa project in Uganda. But then also thinking about equity in clinical training. We have so many medical students and residents who travel to Africa to learn about medicine there and have an opportunity to get hands-on experience, but very rarely do they then, do our colleagues in Africa then get to come to the United States to receive training. And I'll talk a little bit about what we've done in that space to really help to build capacity for cardiovascular disease care in Uganda. So let's talk a little bit about HIV. This is something I've been thinking a lot about since I was a medical student. But the UNAIDS currently estimates there are about 38 million people living with HIV around the world. And as many of us, most of us know, of course, the vast majority of this burden is in sub-Saharan Africa. And importantly, while the majority of the disease burden is in Africa, it's also important to recognize that a disproportionate amount of this disease burden in Africa falls on women. And in terms of incident HIV cases, as well as mortality and outcomes, women are disproportionately affected. shown here in this figure from the GBD in Lancet HIV last year. The male to female ratio is less than 1 in sub-Saharan Africa, where it's over 1 in most other areas of the world. And so all of the research that we do in this space, I think, needs to intentionally think about how women are affected. Obviously, antiretroviral therapy has really revolutionized care of HIV in Africa over the last 2 decades, especially, again, shown here from the GBD paper, where we've seen dramatic reductions in incident cases and deaths, especially over the last decade. And this has led to a rise in prevalent cases as people living with HIV age successfully on the continent. And so we've seen this dramatic fall in HIV/AIDS mortality. And as we see a fall in AIDS mortality, obviously, proportionally, something is going to have to take its place, and that's the non-AIDS comorbidities, things like cardiovascular disease, which we'll talk about today, but also cancer, kidney disease, liver disease. And it's not just because it's proportionally increasing due to the decline in AIDS mortality, but people are aging, and aging is important for all of these comorbidities. But it also appears that HIV itself increases the risk of many of these comorbidities. Shown here is a figure from Steve Grinspoon of the landmark epidemiologic studies that established that HIV is associated with a higher risk of coronary heart disease on the magnitude of about 1.5 to 2-fold increased risk. But importantly, most of these studies, or all of these studies really, were done in Western Europe or North America. And whether or not the magnitude of this relative risk is the same in sub-Saharan Africa, or maybe even bigger or smaller, is just really not known, and something that we're, of course, interested in. Let's just assume that there is an increased risk of cardiovascular disease in people living with HIV in sub-Saharan Africa. But in addition to that increased relative risk, we know that the population impact also depends on the prevalence, and the prevalence of HIV is higher in sub-Saharan Africa, leading to a very high, potentially very high population impact. And this was shown here in work that we did in collaboration with Anup Shah from the University of Edinburgh, where we estimated the global burden of ASCVD to really be quite high in sub-Saharan Africa. If you look at this is the population attributable risk or fraction of HIV for atherosclerotic cardiovascular disease. And you can see in some countries of Southern Africa in particular, it reaches 10 to 15%. As shown here in the appendix, Uganda, where I work, the population attributable fraction is about 5%. And this is similar to other countries in East Africa, but not quite as high as countries of Southern Africa, where HIV prevalence is higher, but certainly much higher than countries that have a very high CVD burden, but low HIV prevalence, such as Pakistan or Kazakhstan. So accepting that there's a residual risk of cardiovascular disease associated with HIV infection, what accounts for that? What is causing that? And much of my early career was spent examining the role that inflammation and immune activation play. But I'll just acknowledge that, of course, there's possibility, because of these are observational studies, that there's residual confounding from traditional risk factors such as rates of smoking, cholesterol, hypertension, et cetera. But I also want to really point out, although I won't talk a lot about it, that the risk associated with antiretroviral therapy itself is probably not as significant as it may have been in the past. You've heard of protease inhibitors and nucleoside reverse transcriptase inhibitors, such as abacavir, being associated with myocardial infarction. But the newer generations of drugs are much more safe from a cardiovascular standpoint. So is it this residual inflammation and immune activation that persists despite effective antiretroviral therapy that is to blame? So what are the tools that we have to investigate this inflammation CVD link in HIV? Well, traditionally in this space over the last 2 decades, investigators have used biomarkers, peripheral biomarkers of inflammation and immune activation to look at inflammation. And then used cardiovascular imaging techniques, vascular imaging techniques to try to assess cardiovascular risk. And so some of those usual suspects I've shown here, things like IL-6, TNF-alpha, but monocyte activation markers such as soluble CD14, soluble CD163, and as well as flow cytometry techniques to look at cell surface expression. And then I spent a lot of my early career learning all of these various imaging techniques such as brachial artery activity testing, carotid ultrasound, cardiac CT, FDG PET CT, and MRI, echo and cardiac MRI to look at cardiovascular disease, subclinical cardiovascular disease. So in terms of the global health reach of this work that I did, in again, mostly in my early career, but still of interest to me, is the Mutima cohort study, which was part of my K23. This was 100 people living with HIV on antiretroviral therapy and 100 age and sex-matched uninfected persons in Uganda, and all were over 45 years of age with at least one risk factor for cardiovascular disease, and those shown here. The baseline visit was conducted in 2015 to 2017 with inviting everyone back for a year 2 exam in 2017 to 2019. And at baseline, we did coronary calcium scoring with a non-contrast gated CT, and at year 2, did CT coronary angiography. And in terms of making this research work, we relied on partnerships, long-standing partnerships with our colleagues in Uganda. Shown here is Dr. Sisi Kitio, the co-PI with me of this study, who's currently the executive director of the Joint Clinical Research Center. I'll speak more about the JCRC in a little bit. But we also partnered with a private not-for-profit hospital in Zambia, St. Francis, and a radiologist there, Dr. Geoffrey Aram, where they had actually a pretty nice CT scanner, 128 slice Siemens Samatom, and we're just really hungry to learn how to utilize this for cardiac CT imaging. And shown here are some of our partners from Massachusetts General Hospital, as well as University of Sao Paulo, Marcio Bittencourt, and Brian Gashajra, who are helping to establish a protocol for the cardiovascular CT and do some training and education with the techs there. So for those in the audience who may be less familiar with cardiac CT, we did utilize non-contrast scans in the baseline exam to look at what's called coronary calcium. You can see here calcium in the LAD. And this can be quantified in a way that is really closely aligned with future cardiovascular events. Although it's not a true visualization of all of the plaque or the amount of luminal obstruction. So our initial study on reporting these findings was published in Open Heart a couple years ago. And it was really remarkable that we did not find nearly as much coronary calcium in our Uganda cohort compared to a similarly aged cohort in Cleveland, despite the fact that our Uganda cohort was enriched for these cardiovascular risk factors, as I mentioned earlier. So only about 10% or so had any detectable coronary calcium, and even many of them had low levels of calcium, less than 100. And so when we did multivariable modeling, we found that Ugandans had a 13 times lower odds of detectable calcium compared to the Cleveland participants. So we wanted to look at this further, but we were interested, as I've mentioned, in the associations of calcium with biomarkers of inflammation and immune activation. And you can see in the multivariable adjusted analysis that in general, many of these markers were associated with disease, particularly soluble CD163, for example, which is a very interesting marker of monocyte activation. So in year 2, we invited participants to come back for an angiogram, a CT angiogram. And again, this is an example of a CT angiogram shown here, which can show you essentially the same information about the luminal obstruction as a cardiac cath, but also will show you about the plaque and whether there's calcified plaque, non-calcified plaque, positive remodeling of the plaque, other high-risk plaque features, which we're learning more and more may be useful for clinical purposes as well as research. And our first publication on these data were published just recently in the Journal of the International AIDS Society, where we describe that, again, there's a relatively low prevalence of plaque overall. But interestingly, we see this very interesting HIV-sex interaction where women with HIV appear to have more disease than men with HIV, which is the exact opposite of what we typically see in the general population and what we see in people without HIV in Uganda. This is in contrast to the reprieve cohort, which is a randomized controlled trial of pitavastatin versus placebo in people living with HIV. Many of you are familiar with this trial, and these data just reported at CROI, Markella Zaini and colleagues show that women, or that females in this study actually had less plaque than males with HIV. So clearly there are differences between the context of the US and sub-Saharan Africa. One of our cardiology fellows, junior faculty, Sateh Shakil, is looking at an analysis of whether the inflammatory markers that we measured at the baseline exam are associated with angiographic disease at year 2, and has shown that the associations are very different in females compared to males, and in particular are generally stronger positive relationship in females, and in some cases even we've seen some inverse relationship with the biomarkers in males with some statistically significant sex interactions. So we're very keen to explore what is it about females and women in Uganda that may be driving these differences. So I'll shift a little bit now in the talk to talk about some of the implementation science that we're doing now, which is certainly a shift from my early career, but very interesting nonetheless. And this is a clinical trial, a UG3 UH3 mechanism from the NHLBI. You can see the title shown there, Polesa Uganda. And generally, the aim of this study is to test different strategies of integrating hypertension care into routine HIV care in Uganda. As a word of, again, reframing this discussion a bit, I want to point out that while I mentioned earlier that the residual risk of HIV above and beyond traditional risk factors may be in part due to incomplete adjustment for those traditional risk factors that are potentially confounding the relationship. But also, when you think about the overall risk, the absolute risk, the population attributable fraction for cardiovascular disease of these traditional risk factors is actually quite high because of the high prevalence of these risk factors in people living with HIV. At least in North America, you can see that these 3 traditional risk factors are much more important on a population level than HIV-specific factors such as low CD4 count or high viral load. This is a bit in contrast to other non-AIDS comorbidities such as chronic kidney disease and chronic liver disease, for which the HIV factors have a little bit more population level impact. So we need to focus on these traditional risk factors if we're going to have a population level impact on disease. And so we believe it is now time to extend the traditional HIV care cascade, where we think of getting diagnosed with HIV, being prescribed antiretroviral therapy, and taking that therapy as prescribed to achieve suppression of the virus in the blood, to also think about extending that to prevent non-AIDS comorbidities, and in this case, cardiovascular disease, by appropriately diagnosing, appropriately managing, and then reaching blood pressure and cholesterol goals. And so this is a figure from our trial here in the United States called Extra CVD, and the protocol paper published a couple years ago, but it is relevant to the Ugandan context, particularly for hypertension. And so that's what we're interested in doing with this UG3 UH3 award. I'd like to acknowledge the many important partners in this work, in particular the Infectious Disease Research Collaboration in Uganda, which many of you may know ran the SEARCH trial. My co-PI there is Fred Simatala. Again, many of you may know Fred from his work in TB and HIV work. The trial will be conducted in the Kiso district and Kampala districts of Uganda. And as I mentioned, it's a phased award. So our goal is to, in the UG3 phase, conduct a formative assessment, which will then inform the development of interventions to integrate hypertension care into routine HIV care. And our formative assessment, which is ongoing, has really been focused on not only describing the current practices of hypertension care in HIV clinics in this setting, but also thinking about what sorts of HIV care innovations are happening in these settings, and then getting together with a design team consisting of important stakeholders, patients, providers, researchers, people from the Ministry of Health, to then, utilizing a CFR framework, think about how to develop an intervention that will address these barriers and take advantage of the HIV care innovations to provide high quality hypertension care for our patients. And the process for doing this is using a human-centered design approach, which I'll talk about. The two implementation strategies that our design team has come up with include what I'll describe as hypertension basic and then hypertension plus. Hypertension basic is alleviating the major barrier that everyone always brings up, which is that people do not have appropriate access to medicines for lots of different reasons, but also don't have appropriate access to blood pressure machines. And so just providing those simple, making sure that those are always available in the clinics, what sort of effect will that have on blood pressure control in the population? And then hypertension plus is saying, can we layer on top of that additional components that may address some of these other unique barriers through feedback and incentives, e-consultation, remote patient monitoring, potentially remote blood pressure monitoring, and other system strengthening and human resource strengthening components. This is our design team that met in October, and we continue to engage them as we're going through a pilot phase of the Hypertension Plus integration. Human-centered design is fun. Getting together involves lots of sticky notes, which for those of you who have done this before is a lot of fun, but also exhausting. And fundamentally, it's a work that involves trying to empathize with the end users, in this case, both patients and providers in these HIV clinics. And this is an empathy map that helps the design team do that work. So when we eventually have our interventions kind of worked out, the plan is to test them in a stepped wedge cluster randomized trial, as shown here. And the primary outcome will be the blood pressure treatment cascade. And in particular, the primary outcome will be population blood pressure control less than 140/90. And we'll be looking at not only the effectiveness, but also the cost effectiveness in this trial. We hope that will begin in later fall of this year. We're hopeful and fairly confident that our interventions will have a significant effect on the hypertension treatment cascade, in part because of work done at the Malago ISS clinic, which is the largest HIV clinic in Uganda and one of the more sophisticated ones as well. So their hypertension cascade, as shown here, was really abysmal, with 5% of their patients being controlled before a small pilot study. And in a Resolve to Save Lives funded LINKS award, we're able to show that over 6 months, a very simple intervention to screen and treat for blood pressure resulted in a vast improvement in hypertension control. And so whether or not this will work in smaller clinics, in government-run clinics, not-for-profit, private not-for-profit clinics, that's the goal of our trial. So I hope not to give you too much whiplash here, but we're going to switch gears now, and I wanted in this talk to not only talk about HIV, but also to talk about rheumatic heart disease, because I think it's a really cool story of how we've built equitable partnerships over the last 10 years to really achieve dramatic improvements in rheumatic heart disease care and ongoing research in this area. So the link here is also that because many of us in this work were coming from HIV world, we very easily could think about how do we think about the lessons learned from HIV and how do we apply that to rheumatic heart disease. So again, a brief primer on rheumatic heart disease for those of you who may not see it very much or who are not as familiar. It begins with a group A strep infection, typically strep throat, but also skin infections. And in a certain segment of the population who are genetically predisposed, you can get this acute rheumatic fever, primarily fever and joint pain, which is an autoimmune response to the group A strep infection, occurring a couple weeks later and diagnosed using the Jones criteria. And in certain patients who are continually exposed to group A strep infections, their valvular heart disease may progress with recurrent episodes of acute rheumatic fever and ongoing exposure to very severe valve damage and valvular heart failure, sometimes at a very early age in childhood or adolescence, but sometimes, frankly, many, many years later, we see patients with rheumatic mitral stenosis showing up in their 40s and 50s here in the United States sometimes. So this is a classic rheumatic mitral valve, again, with the excessive motion of the anterior mitral leaflet, the hockey sticking appearance that many of you have seen. This is treatable with balloon valvuloplasty, and some of our work was really focused on helping our colleagues in Uganda learn these techniques so that they could perform these procedures in Uganda. So I showed the slide earlier of the prevalence of HIV around the world. So 38 million people living with HIV. There are estimates from the Global Burden of Disease study from Greg Roth, David Watkins, and others to suggest there are about 40 million people living with rheumatic heart disease around the world. And again, with a burden of disease that somewhat mirrors the HIV burden, with the addition certainly of countries in the South Pacific that experience a high rate of rheumatic heart disease, places in India and Asia as well. So if there are 38 million people living with HIV and 40 million people with RHD, you would expect then that the global research funding landscape would be that both disease conditions are receiving about the same amount of research funding. Right. So HIV is represented here in this diagram. The amount of research funding for HIV has this circle here. And if you were to express the amount of funding for RHD, it would be that big. Did you see that there? So I tried really hard to get the correct proportions, but actually I couldn't. It should actually be half the size of that small dot. And this was highlighted in a editorial accompanying David Watkins' GVD study on the burden of RHD, as shown here in this table 1. So we need more research. We need more funding for clinical care. But I think that the needle is moving, even though slowly. And I'd like to acknowledge the work of Craig Sable, who is a pediatric cardiologist and echocardiographer at Children's National Medical Center, and his former fellow, Andrea Beaton, who in the early 2010s started to do echo screening studies looking at the prevalence of rheumatic heart disease among Ugandan school children. And this was an AHA top 10 paper from 2012, where they described a 1.5% prevalence of definite rheumatic heart disease, according to criteria used at that time in the populations that they studied. And around the same time, the late Professor Bugani Mayosi from Cape Town and others were assembling large coalitions of people to do registries in their respective countries. And the Remedy study was an important study that began around that same time and really helped to catalyze a lot of interest in rheumatic heart disease. Around that same time, we at Case Western University Hospitals were getting involved in cardiovascular capacity building through the Medical Education Partnership Initiative. I'll talk more about that later on. But I mention it here just to say that as part of that, it was clear to us that our colleagues in Uganda wanted to do work in rheumatic heart disease. And so together, we put together a proposal for Medtronic Foundation to leverage existing HIV/AIDS infrastructure in Uganda and the long-term partnerships that Case Western had with the Joint Clinical Research Center and other HIV treatment programs in Uganda to create a comprehensive RHD treatment program, and really had two main aims, which were to first create a decentralized chronic disease management program for RHD at the regional level, and then also to create within the Uganda Heart Institute an East African Center of Excellence for advanced RHD therapies, and in particular with a focus on mitral valvuloplasty. And so our partner that I mentioned earlier, the Joint Clinical Research Center, really has been at the forefront of HIV/AIDS care in Uganda since the early 1990s, and was a major implementing partner of the antiretroviral therapy rollout over the last 20 years. At the time that we were thinking about this, the JCRC really had a lot of space and staff to do this work, and had a mission to move beyond HIV care into some other areas. Many of you know Dr. Peter Majeni, who was the executive director for many years at the JCRC and recently retired, and now with Sisi Kitio having taken over. But this is a picture of Dr. Majeni, Professor Majeni, next to Laura Bush when George W. announced the PEPFAR program at the 2003 State of the Union address. So the JCRC had this network of clinics within Uganda, which was part of the antiretroviral therapy rollout plan. And so the idea was that we could utilize this infrastructure to roll out a regional, decentralized regional program for rheumatic heart disease patients. And by standing up echocardiography and some nursing expertise and access to benzathine penicillin, which is the standard of care to help people prevent progression from acute rheumatic fever to rheumatic heart disease and progression of rheumatic heart disease. By having these regional centers set up, we hoped to improve care for patients in those areas. And in early work from this program, we had established a registry of these patients in order to track them clinically and make sure they're being adherent to benzathine penicillin. We described the RHD treatment cascade, which was something that we thought a lot about in HIV and something we thought we should do for rheumatic heart disease as well. And as you can see at the time, retention in care was just as much of a problem for rheumatic heart disease care as it is for HIV care, and as it has been for HIV care. But once retained in care, most of these patients were prescribed appropriately benzathine penicillin and were optimally adherent to it, which is what is required to achieve optimal outcomes. So you can see that one of the key predictors of retention is proximity to a regional center for rheumatic heart disease. And so that, again, was the hope, is that by decentralizing care, that we could bring care closer to the client, closer to the people living with rheumatic heart disease, so that they could be retained in care and ultimately complete the cascade by being prescribed BPG and being adherent to BPG. So if you look at completion of those cascade steps and mortality in the registry, we've recently described that as you would expect, mortality is generally worse among those who have not completed the RHD cascade. And so it's important to think too, as with the HIV work that I mentioned, whether or not there are gender differences in rheumatic heart disease care. We've looked at women and men in the registry. Again, these are women of reproductive age compared to men of reproductive age. And when you look at that age group in particular, the retention is even worse than it was in the overall registry. We've been interested in whether women are receiving appropriate care to prevent rheumatic heart disease complications, such as receiving anticoagulation for atrial fibrillation, for example. And again, perhaps because of the concerns for teratogenicity of warfarin, women were less likely in the registry to receive warfarin for AFib and were often being prescribed aspirin instead, which we know is not adequate to prevent stroke. Nonetheless, we are encouraged to see that women generally had somewhat better outcomes than men, marginally better outcomes than men, even though outcomes are not good for either in the registry. So more work in this area, but some interesting observations. One of the women living with rheumatic heart disease who has been instrumental in trying to push the advocacy agenda forward is Flavia, shown here. She has traveled to Geneva to talk to policymakers at the World Health Organization and has helped, I think, move the policy discussion forward. People living with RHD have been at the center of much of our work as we've gone along. And for example, in this 2017 Rheumatic Heart Disease Stakeholders Meeting, we had a whole program for people living with RHD in order to help them participate in our processes. This Rheumatic Heart Disease Action Network of Uganda was part of a larger global effort, which included the World Heart Federation and a global RHD advocacy organization called REACH, and which ultimately culminated in an important resolution, the very first resolution to address rheumatic heart disease by the World Health Assembly in 2018, where countries committed to investing more in rheumatic heart disease prevention and care. And so I think that we're at a point now where there's really been a turning point in the interest around the world to try to address this problem. And there is a lot of ongoing work, which I don't have time to discuss today, in rheumatic heart disease care in Uganda, which really has kind of been spurred by the early work from Andrea and the Medtronic grant. This work is primarily led by Dr. Beaton and but also Dr. Watkins here at the University of Washington through American Heart Association Strategically Focused Research Network grants, as well as they recently scored very well on an R1, which we hope to be funded very soon. Some of the areas we've looked at: acute rheumatic fever incidents, further decentralization of the RHD registry, simplifying echocardiography so that frontline health workers can be obtaining echoes, and then I'll mention penicillin for latent or subclinical rheumatic heart disease in children. This just published in the New England Journal, a clinical trial led by Andrea and colleagues of 916 children with echo-detected subclinical or latent rheumatic heart disease who were randomized to receive penicillin or no penicillin. And what they found was that 2 years later, there was a much lower risk of progression of the disease compared to those who did not receive penicillin. So this has not yet led to penicillin being the standard of care, but the hope is that penicillin could prevent progression to more severe disease so that people do not die of rheumatic heart disease or need complicated interventions such as valvuloplasty and valve surgery. So all of this work has really been made possible because of equitable partnerships. And I mentioned the Medical Education Partnership Initiative. For those who are less familiar, this was established in 2010 by the NIH and PEPFAR to increase the number of medical graduates, the quality of their education, and their retention in Africa, particularly focused on HIV. There were 11 grants to African institutions and $100 million in PEPFAR funds. But in addition, the NIH added another pot of $30 million for what were called linked awards. And there were 2 of these awards in cardiovascular disease capacity building. We at Case Western were partnered with Uganda in this effort. And over the course of the 5 years of this award, we're able to help with a cardiovascular disease risk factor survey, helped co-mentor 25 med students and 3 PhD students, and then really importantly, brought 5 clinicians to Cleveland to train. And this includes the first 2 interventional cardiologists in Uganda and 2 heart failure docs and a cardiac anesthesiologist. It resulted in at least 14 manuscripts co-authored by all parties. So again, this is a picture of the cardiovascular cath or the cardiac cath lab in Uganda at the Uganda Heart Institute. It was established in 2012, but there were no operators to perform coronary interventions. And so importantly, we trained the first two interventionalists. Each did a year of training, interventional training in Cleveland. Emil Kello is one of those shown here with Dan Simon, our chief of cardiology at the time. So this has really revolutionized and kickstarted a dramatic improvement in cardiovascular care at the Uganda Heart Institute, particularly for adults. And the work that we've been part of is really, we're just one partner of many, and the Uganda Heart Institute has been able to partner with others around the world, shown here in red. And I'd like to highlight, because I mentioned balloon valvuloplasty, a relationship that they've had with Minas Gerais in Brazil, where they were able to learn valvuloplasty techniques, go back to Uganda, and are now doing a robust number of valvuloplasties independently at the UHI. So some of the lessons learned about equitable partnerships: clearly they don't happen overnight. It requires long-term personal and institutional relationships. The work that we've done in HIV in Uganda really relied on the long-standing institutional relationships that Case Western had there. But also the important point is that equitable partnerships are mutual partnerships. They're based on mutual benefits, and the needs, the training and research needs, certainly need to be driven by those in LMICs, but must be aligned with the strengths and interests of high-income country partners in order for there to be the highest impact. And finally, they aren't easy to achieve, as is probably obvious, but require active work to maintain. And in clinical training in particular, there are many, many structural barriers, including financing, medical licensing, visa issues, and hospital credentialing issues. But ultimately, I think that it can have massive and durable impact. So we have hopefully about 5 or so minutes to talk about the new Global Cardiovascular Health Program. As I mentioned at the beginning, I want to get you excited about that. And so this was established in November as a joint effort of both the Department of Global Health as well as the Division of Cardiology, with a founding vision to drive innovation that improves cardiovascular health outcomes at home and abroad. Back to that idea of reciprocal innovation. So here are 3 kind of key pillars of a proposed mission to achieve that vision. First, I believe we need to study not only traditional cardiovascular disease, but also these endemic cardiovascular diseases of poverty across the spectrum of translational science, with a commitment to equity and capacity building, so that we can achieve these optimal cardiovascular outcomes for all. And so let's talk about those individually. First, to rigorously study traditional and endemic cardiovascular disease. So traditional cardiovascular disease, I'm talking about ischemic heart disease, stroke, non-valvular AFib, all the stuff that we know very well on the Harborview cardiology consult service here. But when we think about low-income countries like Uganda, there are also these endemic cardiovascular diseases, such as rheumatic heart disease, but also tuberculosis pericarditis, or this entity called endomyocardial fibrosis. And research into those endemic CVDs is even much more limited than rheumatic heart disease. And then finally, we acknowledge that there are countries and other geographic settings where there's a double burden of disease, where both there's a high rate of atherosclerotic cardiovascular disease, but also endemic cardiovascular diseases in places like India, for example. And as these countries develop their economies, there may be a shift from one part of the Venn diagram to another. And helping health systems and strengthening health systems to deal with that transition, I think, is also part of the scope of what the Global Cardiovascular Health Program aims to do. I said, we should study these things across the spectrum of translational science, and I've been interested in the mechanisms of inflammation, immune activation, cardiovascular risk, and HIV. That's earlier stage translational and clinical science. But I think really here within the University of Washington, our strengths and what is needed in the global cardiovascular health space are in population health and implementation science. How do we move the needle on that no-do gap for cardiovascular disease improvement? So I showed this slide earlier, and I'll just emphasize that all of this work needs to be done with a commitment to equity and capacity building in order for it to be successful. And I'll end with a couple comments about reciprocal innovation. Again, the goal is that the work that we do in global health may have implications for healthcare here in the United States. And this is a diagram from DePass and Lee that describes what at the time they called reverse innovation, where innovations happening in low-income countries may come back to high-income countries to help improve care here, maybe further innovated. And then more recently, people have been talking a lot more about the idea of reciprocal innovation, which is a term that doesn't imply that innovation only flows in one direction, but is really a cyclical process. And so innovations from high-income countries may come back to low-income countries and be further iterated. And so I think that the goal is that the work that we do in rural Uganda may have applications to rural Washington. And I look forward to partnering with many of you in the Department of Medicine to help make this happen. Obviously, this work is a massive collaboration of many, many people, some of whom are listed here. I'm sure some of whom I've forgotten to mention or didn't have space to mention. The funding and as well as our research staff and study participants, importantly. So with that, I'll stop and take some questions.
Thank you so much. That was a great talk, and you definitely covered a lot of really interesting ground. So thank you for taking the time out. I just want to encourage everybody listening, do please type your questions into the chat, and then we will get to them over the next 5 or so minutes. But I just wanted to ask a question to start off. You were talking about the decentralized nature of the rheumatic heart disease spaces, like where people are actually accessing the care, which I think is really interesting. And I'm just curious, how did you and the group go about selecting the places that you had those centers, and were they aligned with other programs that you saw were successful, like launching point from those spaces? How did you guys do that?
Yeah, great question. So we utilized the network of the Joint Clinical Center or Research Centers, regional centers of excellence. And they were in regional centers that were strategic because those are population centers outside of the capital city of Kampala. So Mbarara in the southwest, for example, is a very important city in that region. We did start from a regional level because echocardiography is not something that is just easily distributed down to a local health center. It's complicated to learn the techniques. But as we've kind of gone out to regional centers, the next steps, and again, this R01 that David and Andrea just recently had scored really well, hopes to do some of that, right? To decentralize it even further and take it into health centers, health center 3s and 4s. So a lot of picking of these places depends on kind of geographically what's strategically important, but also what exists in terms of resources and connections and existing partnerships. Again, it goes back to those existing partnerships.
Got it. That makes a ton of sense. Thank you. A couple questions coming in the chat now. So one is wondering, are you and your team looking at some of these same questions for populations of Africans who have emigrated over to the US and maybe carry some of those similar risks?
Yeah, absolutely. We haven't done a lot of that, but kind of the group of collaborators has published some data on acute rheumatic fever in the United States. It's, certainly when we see rheumatic heart disease at Harborview and elsewhere, it's often in these immigrant populations. And I'd be very interested in talking more with folks who are interested in that. And yeah, it gets back to that reciprocal innovation idea.
Great. Another question comes from one of our residents, and she's wondering, are the HIV programs pay out of pocket for the hypertension medications? I'm just curious what the average cost per month of meds for hypertension is for those patients?
Very, very important question. We have collected those data and been very intentional about trying to collect out-of-pocket costs for our patients currently in kind of this current standard of care. So currently, people with HIV get their HIV care at an HIV clinic, and then they will often go to another clinic if they also have hypertension, and they have to pay out-of-pocket most of the time because the government clinics in Uganda that may supply medications often are out of stock. And so the most reliable way to get it is to go to a private pharmacy. And so we are collecting those out-of-pocket costs, which include not only the cost of medication, but also the cost of transportation to get to the clinic. So if you have to go to 2 different clinics, that's 2 bus rides, it's 2 days off of work, rather than having integrated care where you only have to travel once to clinic. So we're assessing all these costs. I can't give you the exact numbers right now off the top of my head. We're actually analyzing some of those data right now. And so stay tuned and happy to report back to you on that.
Excellent. Well, thank you so much. We have another minute or two if people have other questions in our chat, but I think you've answered everything so far. Oh, we do have another one. How does the COVID-19 pandemic impact the rheumatic heart disease care utilization?
Yeah.
If you are able to say.
Great question, Yangfang. I unfortunately am not in a position to answer that question for you. I think that in general, it really impacted Uganda when they went into full lockdown, and that happened more than once. And so getting benzodiazepine penicillin is difficult in those situations. But more importantly, probably is getting care for heart failure decompensation. And so I can't say for sure. We could look at that in the registry and see if there was an inflection point in mortality, for example, when COVID hit. But as you know, Yangfang, from the work you've done with the registry, that it is a very high mortality in Uganda, and so unfortunately, that's the reality that we're trying to work with.
Great.
Well, thank you so much for the invitation.
Thank you.
This was a lot of fun. Hope people are excited about the Global Cardiovascular Health Program. Clarification for the RHD trial. No, it's given given on a monthly basis, just like we do for other participants or other patients with rheumatic heart disease who have an indication for BPG.
Excellent. Well, thank you so much. We'll let you get back to your team, but have a wonderful afternoon, everybody. Thank you again, and take care, and we will see you all next week.
Thanks. Bye-bye.
Have a great week and weekend, everybody.